Okay, good morning everyone. My talk today is about arthritis of the knee. I'll go over some general characteristics, clinical features, how to do a functional assessment, the investigations involved, and also talk about treatment options. But I won't be going into arthroplasty because that will be discussed in a few weeks' time by, I believe it's James. The knees are the most common joint that's involved with osteoarthritis. Some predisposing factors may be injury to cartilage, previous meniscal tears, any instability with regards to the ligaments, or any deformity of the hip or knee. Sometimes the obvious causes might not be found, and it often can be bilateral. In terms of being the most common joint involved, if we look at the OIA, National Joint Registry, we can see the amount of knee joint arthroplasty which is done each year. And last year there was over 46,000 joint replacements done. Compared to hip arthroplasty, a bit lower with just over 37,000. And again, even lower when you go to shoulder arthroplasty and elbow arthroplasty. So it's quite common. Some other general, it's the most common form of osteoarthritis. It's a non-inflammatory arthrosis. And again, primary and secondary factors can be involved. Usually in patients that are older, trend in terms of patients being overweight. Various knees are more common, and also women more common than men. There's a deterioration and loss of the weight-bearing surface, which is the cartilage. You get cartilage fibrillation, sclerosis of the subchondral bone, and also osteophyte formation. You can get subchondral cysts, which is secondary to microfractures which occur, and then the healing process of that. And essentially, eventually joint space narrowing as the cartilage wears away. And then the complete disintegration of the cartilage. In terms of clinical features, when we see patients in our clinic, they're usually complaining of pain. And that's, the main complaint. It can be worse after use. Going up and down stairs may also be a problem, depending if the patellofemoral joint is involved. And after rest, they usually feel stiff. Swelling can be a feature, giving way or blocking. And they often complain of exacerbations of pain and stiffness. And also another feature is a loss of function. So their usual activities of daily living is something that they have trouble with doing, and they can't really do or have trouble doing things that they've previously done before. On examination, you may find quadriceps wasting, reduced range of motion, and joint stiffness. Also, angular deformities, whether it's a varus or a valgus knee. Again, varus is more common. And a fusion may be present, and in more severe cases, osteophytes may be visible under the skin. They may complain of joint line tenderness or tibiofemoral joint line tenderness, whether it's medial or lateral, and also patellofemoral joint tenderness if that joint's involved. Joint crepitus, and also pain with the varus or valgus forces when you range the knee. You may indicate which compartment's involved, and they all often have an antalgic gait. In terms of a functional assessment, there's a variety of different scores available, which all look into how a patient functions in activities of daily living. I'll go into a few of these that I found. I haven't seen any of these scores used here. I guess it's a hospital or surgeon dependent in terms of what they like to use, if they're using. With the Oxford knee score, it's a patient-reported outcome questionnaire, so the patient usually fills in the form with or without the assistance of the physician. There are 12 questions, and they cover pain and function associated with the knee. And it's aimed to evaluate the knee and the function of the knee before any treatment and also after arthroplasty, and we compare the results over a period of time. It's a short questionnaire, it's practical, it is reliable, and it's valid. And it's sensitive to clinically important changes over a period of time. And here's just an example of it here, which basically goes over questions related to pain and function. In terms of the scoring system, the highest score you can get is 48, which is a perfectly functioning knee. 0 to 19 is pretty bad, indicates that patients have severe arthritis and they most likely will require joint arthroplasty. 20 to 29, they have moderate to severe arthritis, and it's likely that they'll be having an orthopedic opinion and they may eventually have arthroplasty. 30 to 39 is mild to moderate arthritis and indicates that patients can be treated non-operatively to start off with. And then 40 to 48, where the knee joint function is satisfactory and doesn't really require any treatment at all. Another score is the Knee Society score, or the KSS. That was first developed in 1989. And again, that's a simple and objective scoring system, which rates the knee and the patient's functional abilities. And it's also, like the Oxford knee score, done pre and post the total knee replacement. However, that was done over 20 years ago, and I guess the joint arthroplasty has changed in the last 20 years, and also the expectations of the patients. Also, they have, I guess these days, they have high demands and they've got different functional requirements. So this was revised. It took 4 years to do so, and they completely reviewed this scoring system. So the new Knee Society score was released last year. Again, there's a physician and a patient component to it, and again, pre and post operative components. And they look into demographics of the patient. There's an objective knee score where the physician fills in, looking at the alignment of the knee, any instability, and the motion of the knee joint. It goes over symptoms, mainly related to pain, patient satisfaction, expectations of the patient, functional activities, and any other activities that they may like to do. Another score is the WOMAC, which is the Western Ontario and McMaster University's Arthritis Index. And the purpose, again, is to assess the pain, stiffness, and joint function. And that's composed of 24 questions, which are divided into 3 different groups. There's 5 questions related to pain, pain with walking, going up and down stairs, getting in and out of bed, sitting and lying and standing. 2 questions related to stiffness, and 17 questions related to function of the knee joint. And this is a patient-reported questionnaire, and it's available in the Likert type or a visual analog format. And in terms of the interpretation of scores, so the higher the score, the worse the pain, stiffness, and limitations with joint function. And here's an example of the WOMAC score. So again, this is a Likert format where 0 is none, you've got slight, moderate, and extremely is a 4. Another one is the POOS, so the knee injury and osteoarthritis outcome score. That was developed in the 1990s, and that's assesses the patient's opinion about their knee and any associated problems with their knee joint. It's used for knee injury as well as osteoarthritis, and it can be used over short and long-term periods or intervals. So you can look at changes from week to week with regards to any sort of non-operative treatment that they may undergo, or over a period of years with regards to post-joint arthroplasty. There's 7 subscales relating to pain, any other symptoms that they may have, function related to activities of daily living, and also function related to sports or recreation, and the general quality of life. A score of 100 is the highest you can get, where the patient has no symptoms, and 0 is when they have extreme symptoms. Before I continue, is there any, I have a question of myself, is there any of these scores that any of the surgeons use here?
I've got a question, but we'll leave it.
Oh, okay. So in terms of investigations, the main investigation that we do is plain radiographs of the knee joint, where we look at the decreased joint space over here, where the cartilage wears away, subchondral sclerosis, and also the development of osteophytes and subchondral cysts. Now, at Western Health, we have a protocol with regards to taking x-rays of the knee joint pre-operatively. The first one is the x-ray of both knees, 8 weight-bearing views, and also weight-bearing PA x-ray with 20 degrees of flexion. Then we x-ray the affected knee. You have your non-weight-bearing AP, lateral, your intercondylar, and your skyline view. And finally, the long leg alignment views. So here's some bilateral x-rays, which are weight-bearing x-rays. We independently weight-bearing each leg in turn. These are the weight-bearing x-rays, the PA views in 20 degrees flexion, which are used with the aid of fluoroscopy. Your AP non-weight-bearing x-ray and your lateral x-ray, and your intercondylar and skyline views, and your long leg standing AP x-rays, which looks at both lower limbs and is for alignment purposes. In terms of treatment, again, with orthopedics, there's the operative side and the non-operative. With operative, I guess when a patient has persistent pain that's not responsive to any conservative measures, you may consider operative approach if there's progressive deformity or instability, and if the patient has a loss of function or disability. Older patients with osteoarthritis will tend to eventually have a total knee arthroplasty, which has proven to be rather successful. However, younger patients or athletic patients with osteoarthritis, the management of that isn't clear cut. It can be controversial. The American Academy of Orthopedic Surgeons released a guideline in 2008, which looked at the non-arthroplasty options of the treatment of osteoarthritis. And in 2009, they published a summary of this in JOS. And that was developed to include the less invasive treatment options other than arthroplasty. And it was based on systematic review of published studies that were available. And they provided practice recommendations based on this. And the idea was to help improve the treatment of osteoarthritis based on the current best evidence that's available. Now they found fair evidence and suggested that patients should consider self-management education programs where they undergo activity modifications, for example, walking instead of running, and any alternative activities. They found that there was a significant improvement in pain. They couldn't really comment on the clinical importance. The effect wasn't large, but when you combine the population as a whole, it's probably beneficial. And it's a low in cost. There's not really any harm associated with it, so they suggested that this is a good thing. Weight loss, I found that there was good evidence with regards to this, and they recommended that patients who are overweight, so a BMI of greater than 25, and had symptomatic arthritis of the knee, should lose weight, or be encouraged to lose weight. And they said that a minimum of 5% of the body weight should be lost and maintained at that lower weight with dietary modifications and exercise. Overall, there was a functional improvement. They used the WIMAC score to assess this, and obviously there's other health benefits associated with weight loss. Low impact aerobic fitness exercises was also recommended. So they found good evidence with regards to this. For example, walking or cycling. It did have an effect on pain relief and disability. Again, this is a low-cost option, and there's also additional health benefits with this. Quadriceps strengthening did have an effect on pain and function. Statistically significant, clinically they didn't comment on. And again, no associated harm, so they suggested the patients should undergo quads exercises. Patella taping. There was some evidence with regards to this. It was short-term relief of pain and improvement in function. They looked at medial taping, which decreased pain on movement. Range of motion and flexibility exercises. There wasn't much evidence with regards to this. There weren't any actual published studies. It was level 5 evidence, looking at expert opinions. But because it's low in cost and there's potential benefits with these exercises, they consider this as an option that patients can have. Oral analgesics are looking at paracetamol and non-steroidal anti-inflammatories. There was fair evidence suggesting that it does make a difference. Have patients with increased GI risks had the option to use topical NSAIDs or NSAIDs with a gastroprotective agent or COX-2 inhibitors. Intra-articular corticosteroid injections. They suggested that this can be used. It was effective for pain relief, however it was limited. It was only short-term relief for up to about a week, and there was little evidence that suggested that it had longer-term effects. In terms of surgical options or non-arthroplasty surgical options, arthroscopy with debridement or lavage wasn't really recommended. There's no good evidence that this works. And there are potential, because it's a surgical procedure, there are potentially increased risks. However, arthroscopy in the presence of, say, a meniscal tear or any loose bodies, it was suggested that this can be an option. Again, the evidence, there isn't that much evidence out there, and additional studies are warranted, but they determined that it is an option. Realignment osteotomy in patients with unicompartmental OA with malalignment. Again, there's not very good quality evidence with regards to this. Benefits lasting up to 2 years post-operatively. and they've suggested that this is an option that patients with unicompartmental OA have. Things that were not recommended was the use of glucosamine and or chondroitin sulfate or hydrochloride. That wasn't recommended. There wasn't really any evidence that showed that this works. Lateral heel wedges, again, with medial compartment OA, they suggested that this shouldn't be used because it doesn't really make a difference. Needle lavage, where you, under sterile technique, inject saline and then remove it. There's a lack of evidence showing that this actually works. And free-floating interpositional devices for unicompartmental arthritis. There's pretty fair evidence against the use of this, where they looked at a case series and also the AOA joint registry, where it's no longer used here, and they showed a high secondary surgery rates. So 32% of patients ended up having a revision to a total knee arthroplasty at 2 years, and 62% at 6 years. Treatment methods that were inconclusive, so neither for or against were using braces with valgus or varus directing forces, depending whether it was medial or lateral compartment OA. Acupuncture, there was conflicting evidence with regards to that, and the use of visco supplementation, again conflicting evidence. And also tibial tubercle osteotomy in patients with patellofemoral osteoarthritis. There weren't any available studies, and they were looking at expert opinions only, so level 5 evidence. Arthroplasty, which wasn't discussed in this summary in the JOS. So older patients with progressive joint destruction, it's a resurfacing procedure, unicompartmental. If the arthritis is confined to one compartment, or total knee arthroplasty. I won't go any further into this, as it will be discussed in a few weeks' time in detail. So in summary, the knee is the most commonest joint affected with osteoarthritis. Pain, loss of function and deformity are the main features. The Western Health has a radiology protocol on how to take x-rays preoperatively and also postoperatively. And there's a variety of functional assessment scores available. Recommended treatment options, weight loss, so the non-arthroplasty treatment options are weight loss, low impact aerobic exercises, which were recommended. Other suggested treatment options were activity modification, quad strengthening, patella taping, oral analgesics, and corticosteroid injections. And other options are range of motion exercises, arthroscopy in the presence of torn meniscus or loose bodies, and realignment osteotomies. Thank you.